So I'm going to start the recording, and a really big welcome to everyone who's been able to join today. I'm really looking forward to this conversation. Welcome to the Disability Inclusion Community of Practice, which is part of the Transforming Children's Care collaborative platform. As I said, I think already, anyone who's coming in new, please do put your name and say hello in the chat as we get started. I'm Beth Bradford. I'm the Technical Director for Changing the Way We Care, which is a global initiative working on care reform. And I'm one of the co-chairs or co-organizers of this community of practice, and really happy to be welcoming our speakers today. We'll have about an hour and a half, which is a good amount of time to hear from two speakers and then to have discussion. So because this is a community of practice, a shared space to share experiences, ideas, celebrations, struggles, and challenges, I really want to welcome everyone to be listening with that in mind, and to be thinking about how you want to engage in the discussion part of today's session after we hear from the speakers. If I could just ask everyone to mute if you're not speaking, that will be helpful, I think, for the sound. We really want to make sure that we're hosting a conversation, that people can ask questions, that we can grapple together with some of the challenges that we have in our work. And I'm going to introduce our speakers in just a moment. You're welcome to use the chat to note your questions, but if you can hold those until after the presentations. Again, we should have plenty of time for questions and for discussion at the end. So really happy to be introducing today's speakers. Generally, how we've used this community of practice is a space to have short presentations followed by discussion, question and answers. And today we're talking about supporting reintegration of children with disabilities and transitioning residential care to community services. So our speakers, we have three speakers joining us today, two from Tajikistan and one from Rwanda. Really looking forward to hearing your experiences. Sonia is an early childhood development officer at UNICEF Tajikistan country office. She's been in that position since 2019. Her major areas of work are early childhood intervention and prevention of disability at young age, supporting ECD primary health care levels, and parent work. She's an advocate for young children and early childhood development. And under her portfolio comes the transformation of baby homes to community-based early childhood services. So looking forward to hearing from you, Sonia. We also have with us Salahuddin, who is working as a child protection officer within UNICEF Tajikistan country office. He's been doing that work since 2011, and his major areas are alternative family-based care, social inclusion of children with disabilities, child protection system strengthening, and child protection in emergencies. Along with the transformation agenda that we're going to hear about today, he works closely with the government of Tajikistan to promote family-based alternative care and community care to prevent children from being placed in institutions to begin with. One of his roles is to build the capacity of child protection staff and ensure gatekeeping mechanisms are effective. And then we have Innocent Habimfura, I hope I'm doing okay with names, who carries a dual role as both the regional director for East and Southern Africa and the country director for Hope and Homes for Children Rwanda. Innocent is a trained social worker and lawyer. He's been working in child protection and care reform for 16 years. He led the deinstitutionalization pilot for closing orphanages and centers for children with disabilities and the scale up of care reform nationally in Rwanda. He's facilitated learning exchanges and provided technical assistance to a number of other countries in the East and Southern Africa region, and contributes to advocacy for the social service workforce and development of training. Innocent was recently elected president of the Rwanda National Organization of Social Workers. So a big welcome to our speakers. I'm really glad to see we have a few more people joining us today. Please do introduce yourselves in the chat as we go along. And with that, let's go first to Innocent to hear more about the work of Hope and Homes in Rwanda and other countries. And the decades of work that Hope and Homes has been doing, working to support reintegration of children with disabilities from residential care to families. Over to you, Innocent. Thank you, Beth. Today, again, we have this golden opportunity to share with our colleagues across the globe of what we do, but also with the mission with the aim to hear also from what they do, so that we keep improving the services we have for children, especially children with disabilities. Yes. We've been supporting the reintegration of children with disabilities, first of all, as a pioneer, after another phase where the focus was on orphanages, the so-called orphanages, institutions for children without disabilities. But through the same, we had the opportunity to meet with children with disabilities, and the discussion at that time was,
there will be other pictures.
Yes, I was just saying that with the progress in closing the so-called orphanages for typical children, reaching at around the 91%. So currently we are remaining with only 4 residential centers for orphans. I mean, again, I'm saying in 2 quotation. And after that, when we're doing that work, we were exposed, or we met with children with disabilities who were even in those centers for children called orphanages. The work started, and a number of 144, if I really remember very well, was also supported to go back in families. And I will say that all of them now live in families. So that gave us the courage to also think about phase 2. Here I'm talking about phase, focusing on the target groups. So the second target group was on children with disabilities. So now, Center for Children with Disabilities. Again, Hope and Homes for Children carried out the pilot closures, 2, mainly one in the Kigali and another in the Riro area, to make sure we have the learning on both sides. So we have like a full package, a full understanding, a comprehensive understanding of circumstances of children living in centers for children with disabilities. Can we move on? In the meantime, I will highlight a great collaboration between the different partners. I'm representing Hope and Homes for Children on this call, but I think I will also, even if I'm not mandated, recognize the contribution, the great contribution of UNICEF, the government, under the leadership of the government of Rwanda. All of us, we are working under their leadership, but I think I will be coming back on that. So if I focus on, sorry, can you, this I touched somewhere, sorry, I need to reposition my view. Yeah, children with disabilities are often separated from families and put in institution. This is like an accepted way. Children with disabilities, when found in centers, everyone will say they are where they should be, unfortunately. And their right is already abused. And here I'm referring to the right to live in a family.
But that goes beyond that, because in some circumstances, they are not to be recorded. They are cut from connection with their families. So even the identity right is also affected. And here we will also consider the negative effect of institutionalization of children, as they are exposed to discrimination. They are exposed to all forms of child protection concern. This is neglect. And here neglect, I'm not blaming the institution owners or managers or staff. I'm just referring to the big number which is under their care. So neglect will come obviously as a result of institutionalization and other harmful practices that violate the Convention on Children with Disability. I mean, not children with disability, but the Convention on the right of persons with disabilities. We can move on. Why children with disabilities end in institutions? Here we will find that there are 3 levels. We tried to tackle or to facilitate our analysis of why they end up in institutions. And we realize that stigma is still high. Stigma and discrimination is still high at family level. It's really perceived by educated people, not just perceived, but also from the opinion of educated people, church leaders, officials, where they will say, they will not only stigmatize the child with disability, but even the family will be put under a certain category, especially because of traditional belief here, where everyone will be like blaming the mother of the child with disabilities that she might have done something wrong. So this is like a punishment, some kind of spiritism around. So the stigma is so high. And the lack of awareness around the disability is another issue. Family conflict, as I said, there are discussions always, the husband saying, in our family, we've never had a child with disabilities. This might not be mine. You should tell me where the child is coming. And the conflict will be obvious, and it will take much time until the child is abandoned or placed into an institution. Death of parent as well, and poverty. Poverty because families that are, let's use well off, or that have the acceptable minimum living standard, will very rarely place their children within institutions. So they will remain with their children, they will keep their children with them, and try to push for them to participate in inclusive services, which is not of access to persons who are under poverty. And at community level, we'll say there is lack of support services. So you go in many communities, you can't find a daycare, you can't find a respite care, you can't find specialist foster care. So lack of such services really expose children to going into institutions, but also the existence of institutions, as we say, with its own pulling effect. As I said before, everyone will attend, and that is at the level of the general population, regardless of the category of level of living or education. The general population will tend to believe that children with disabilities are well cared for when they are in institutions. That is the existence of institution trying to corrupt the mind of the general population. And the discrimination, as we mentioned, as I shared before, is not only at family level, but also at community level. It is expressed. It is expressed from community members, and they are not shy to say it. And that's why some services will be discussing, are trying to address the issue of discrimination. And the existing prejudices around the disabilities, those kind of blaming, attacking families, not attacking with stones or whatever, but for example, not giving for rent a family that has a child with profound disabilities, with an idea that it will affect the family that is renting the house to such family. It's an issue we met with. And at the structural level, I will say that, yes, laws may exist, but when they are not enforced, they remain like the lack of those laws and policies and strategies. So many is happening now. Many laws are being developed, many policies put in place, especially around the social protection. As we mentioned, disability is very, very close to poverty. Either it will not allow, poverty will not allow children with disability to access services, or the pressure of the costs for caring for children with disabilities, including medical treatment, including specialized school, will pull families' income towards poverty. The lack of agencies mandated to apply the rights of persons with disabilities. I will say that some progress are happening, especially with the National Council for Persons with Disabilities here in Rwanda, which has also decentralized levels, and it is trying to fill that gap. But all those were the reasons why children were being placed in centers, in institutions. But beyond that, we always say the lack of action, because they are known, but nothing happens, or they are not known, and they remain hidden. So even the case of child protection concern is much higher than being known and not receiving the services. Can we move on? So I touched a bit about the institutions, how they harm children with disabilities. And I'm happy to repeat it. Children with disabilities are exposed to neglect, to abuse. And on abuse, I can refer to a number of children and young people who had mental health issues. I mean, they did not receive any treatment, but within the same orphanages, they were isolated. They were put in an institution within an institution to make sure they are not in contact with anyone. But through the process of the institutionalization, we realized that those described as violent, as abusive, how they were, I mean, described, or those who were like considered as being dangerous become gentle citizens in Rwanda after they received the support within the family. After they, I mean, the case managers started hearing their voices, trying to understand what they mean, and giving them room to express their emotions, their feelings, their choices. They become even more kind people. Let's not exaggerate, but everyone has accepted them, and they started participating in community work. And they're affected by psychological violence, very bad words, very bad messages, like rejected by everyone. They are also victim of sexual violence. They receive over drugs. So anything that happens, there is a piqûre. They received some drugs. So when sometimes it is not necessary. Denial of education, denial of contact with families, and loneliness. You'll find majority of them are put in isolation as serious criminals, just because the institution can manage when their way of behaving, which is unique as anyone, but which sometimes is beyond control of the less staffed institutions. Can we move on? I will also, I'm also happy to share these three elements, just as it happens for children without disabilities. We have realized that these three are pillars toward a successful reintegration of children with disabilities. Yes, they could be will. That's why you find that in many laws, they are clear in supporting children with disabilities, in supporting them to live in families. But because there is no a dedicated cadre of professionals that I call here social workforce, they will end up seeing children in institutions, seeing other institutions opening, or seeing children remaining in institutions as they were. So nothing happens in terms of reintegration. So the social workforce trained with very adapted tools we've diversified more than for children without disabilities, because here there will be introduction of other medical specialties, especially to understand the circumstances. We don't use, of course, the medical approach in supporting these children, but we apply much the right-based, but at the same time, through the assessment, there is need to bring in more specializations. And the reintegration process is another pillar, very important, plus repurposing institutions. Until there is a clear image of what an institution will become after reintegration of children, you will have, I mean, the agency reintegrating children will be exposed to a big danger of not receiving information, of having much resistance from owners, from managers, from whoever. But whenever there is a clear image of what the institution will become, like a daycare, they become more cooperative. Let's move on the details. So the social workforce in Rwanda is composed basically by social workers and psychologists. Here I'm referring much on those dedicated for reintegration. But when it comes on the whole intervention plan, you'll find even people from the education sector, health sector, people from cooperatives who may support resilience of families in terms of economic strengthening, and so and so. And they are based at district level. Of course, they started by being based by each institution, but at the end, they are affected to district to continue providing preventive, but also continuum of support to reintegrated children, especially children with disabilities. And you'll see that the NCPD is the National Council for Persons with Disabilities, is also a key actor because we are working in the sector of disabilities. So from the district, we will have a disability district mainstreaming officer, DMO. At the sector level, we'll have NCPD coordinator. NCPD, I will not define it again. It's that Council of Persons with Disabilities. But also there is an IZU. IZU is a kind of paraprofessionals that was established to fill the gap of professionals in support to families at each village. So at sector, there will be one of their coordinator, and the structure continues the same way. But the paraprofessionals will be much visible at cell and village level, and there is a clear pathway of reporting. This effort has been supported with a lot of effort from UNICEF, of course, the government of Rwanda, and training was provided by a number of other actors, including Save the Children. Yeah, the integration process, I will not describe much the way it is presented, but it is much about how it is conducted. For children with disabilities, as children without disabilities, the first step, if I move from the engagement or education of owners and managers, I will say that there is a focus on assessing each individual child, try to conduct tracing. I will bring here a particular element of children with disabilities in Rwanda that, of course, most need the tracing, but at least majority of them could, remain with contact with their parents, because it was accepted for a child with disability to be placed in an orphanage. So it's something accepted, normal. Although the government doesn't have any center of such, they are all private owned. So the process is that when the family is found, there will be an assessment to check if it is suitable, if it is okay. And if there is a negative result, let's say the family is not suitable, is not, cannot take care of the child, after analyzing the best interest of the child, the alternative care will be found. And here alternative care is much about families. So we are talking about kinship care, we are talking about even adoption, we are talking about supporting siblings to stay together. So another element is the specialist foster care. So foster care that are selected from a long list of foster care, and who accept to take care of children with disabilities. These are the services we've been working with. And there will be, of course, a support, intensive child and family preparation when the family is selected, or the alternative family-based care is selected, plus an intervention plan, and then post-placement support, and all of these to check if the child placement will be sustainable and is smooth at the level of the child to get really better outcomes within the family. Can we move on? Of course, this process requires a lot of effort. That's why we always say it's better it is conducted by professionals, social workers, or psychologists, and it is not enough to have a degree, but also some training also follows. Here is a repurposed institutions. This is an example of a repurposed institution, but in Rwanda, we have been able to repurpose two, and they were transformed from residential care center to becoming, one has become a model inclusive ECD, an early childhood development center, but which is very, which aims to be inclusive and which is operating as an inclusive center, also to have that kind of influence that wherever ECDs are established, this is a big policy here in Rwanda, the inclusion is prioritized. And with which purpose? To identify children at early stage and be treated for those that can be treated or receive medical support when it is less painful, when it is redressable, and when it is more, it is more acceptable, because when they grow older, it's even difficult to recover from the disability itself. So one was caring for 26 children, now is caring for 83 children with disabilities in the community. And another had around 40, up to now, it has 79. The number are not well represented here. So 60 children are in ECD. This is the one in the rural area, plus 35 who attend karate club. Those are children mixed with those with disabilities. 22 in adult literacy, not only literacy, but as a way of supporting parents in their parenting skills. There is a community outreach that is focusing on 140 children with disabilities and much more. All those services were not when the center was residential, because it was only receiving children. But now, after the repurposing, they have recruited specialist professionals who are providing support for children within the center, but also in the community. I think you can see the types of specialization: occupational therapy, special needs education, physiotherapy, and other more. Yes.
Five more minutes, Innocent.
I think I will be done.
No,
Yeah.
no hurry. It's really interesting, but I just wanted to give you a time check.
Thank you so much, Beth. So far, I will say that this program of reintegrating children with disabilities has already placed 49 children back in their families, in their communities. So these guys have once again regained the right to live in family. And we should also remember that now also their families have been supported to know how to take care of the children and the young people. Two institutions I had already mentioned were repurposed, and this is a great motivation, not only as a motivation for managers and owners of the institution or staff, but also the center come back on its real mission, because whenever you read that the mission of Centers for Children with Disabilities, including the residential center, is to provide specialist services, which will never happen in an institution. But when they are repurposed, even those services are provided. And I had mentioned the lack of such services in communities. So when an institution is repurposed, it becomes that, that kind of services, those kind of services are available for the entire community. Like one had already identified over 450 people with disabilities. So not only children, but also adults who will be receiving CBR, community-based rehabilitation services. This is an addition from their own initiative. And we are in other 2 new institution closures, but also another initiative of UNICEF is closing other 2 institutions in Rwanda. So which means that will be around 6 over a number, which is not so big, but which was enough to affect the lives of children with disabilities. And we were about to leave them behind. Yeah. With the prevention services, I think it's very important to know that a reintegration without prevention, you end up continuing in the same circle. You are criticizing institutions and still relying on them. So the prevention will be, I mean, as we always say, prevention is better than cure. There are prevention services to make sure children remain in their families. And whenever there could be a need of alternative care, the institution is not part of option. Rather, there are families. I mean, I mentioned foster care that are prepared to take care of children with disabilities. So the pillars again remain through the social workforce, and here the list will be long. I mentioned to have the social workers, psychologists, local authorities. Now they are also part. We can include them in the workforce because we have a gatekeeping mechanism where CDN, Community Development Network, that has become now Child Protection Networks, but it's the same profile, the same structure, the same content, but I think the name is more responding to the current need. So child protection networks bring together the social workers, psychologists, local authorities, those community volunteers who support children in families, plus community health workers. They are all involved in working like one task force, and they meet on a regular basis, or depending on the need that has come to ensure prevention. And they deliver prevention and they respond on child protection concerns, rather than saying one staff is in charge of it. It's now like a team discussing together and trying to find solution together. The civil society organization, faith-based organization, and here I'm referring to the Catholic Church, for example, which has a big representation for the centers. So on one side, they started the institutions, but they are now the pillars of developing center for, daycare for children with disabilities and other service providers. It's not the Catholic Church alone, but currently, I will say they are overrepresented in providing such services. And if you move, I think I still have 1 minute. Yeah, so the prevention works this way. It will be almost the same protocol. It's a case management protocol. I will not describe it much, maybe through the question and answers, but it's assessing the child who is found abandoned or in child protection concern. And there is an assessment, there is tracing, there is a way of trying to see if the child can return in the family. If not, the child is provided an alternative care. And here we are talking about kinship care, adoption, foster care, but with the purpose of funding the family for integration again. So this is very key. And as I can say, the prevention has stopped an entrance of children within institution. I'm saying stop, but you'll find 1, 2, 3 cases from a big number that should have occurred, because the prevention is working. So without having prevention, we'll be just placing children, and tomorrow others the others remain in the institution. They still face the poor services. And I think that is the way I will end by saying you can't think about reintegration without thinking about prevention, without thinking about support to families with children with disabilities. It's not just removing them, it's making sure they have better services. Thank you so much. If I stole 1 minute, bear with me, please.
We gave you that 1 minute with pleasure. It's a great final point that you're making, Innocent. Really, really really informative and relevant presentation. Thank you so much. I hope participants are beginning to note their questions and topics for discussion. And feel free to use the chat. I'll try to track those questions. But before we go to questions and discussion, let's turn to Sonia and Sohodin to hear how UNICEF in Tajikistan has been working with government and partners to transform institutions for young children into community-based support centers. I think we all grapple with this question of what organizations can do to really support children with disabilities in families. So over to you, Sonia and Sohodin.
Thank you, Beth. Good morning, good afternoon, good evening, colleagues. I'm happy that we are given this opportunity to take through the process of transformation that happened for baby homes in Tajikistan. And I'm very happy that we have also colleagues joined from the different parts of the world who greatly contributed to this process of transformation. Before going to the main content of the presentation, I would like my colleague Sonia to talk about the picture you see in the slide, Abdul Kholiq, the name of the child you see in the slide, and we'll continue to the main content. Sonia, please.
Thank you, Salhidin. Good evening, good morning, good day, colleagues, and it's really great to meet you all here. And just to, this is just to remind us that behind all the work that we are doing there is a human story, and therefore today I just briefly would like to share Abdul Kholiq's story. He's 3 years old, and when he came to primary health care for the routine health checkup, the family doctors had identified developmental delays, and based on the work that the family-based support centers were providing in remote areas, Tarafshan, they referred the family to the center to get support. And Abdul Kholiq, he is 3 years old, and he was not vocal at the time he started his rehabilitation at the center. And he, because his father was in immigration, his mom had to go back to parental house and shared one room, with other extended family members. And there was no very much attention provided to the child's development because of the poverty in the family. They were really focused on getting a bread, daily bread. So as soon as the Abdul Kholiq was at the family support center, he and his family shared that they found the oasis where they could bloom and grow. And even though the 6 months of the program had passed, and they are ready to continue the life independently, and Abdul Kholiq had started to speak, and his vocabulary had grown, and his communication and social skills were developed. He really likes to come to the center now and then just to be in that oasis and spend time together with the professionals who had kindly supported and accepted him as he is. Thank you.
Thank you. Thank you, Sonia. Thank you, Sonia. Beth, can we go to the next slide? Yeah, thank you. Residential childcare institutions in Tajikistan, they are state-run, so they're all funded by the government, and they are under the different ministries. Baby home is under the Ministry of Health and Social Protection. Despite the fact the policy for the baby homes were made at the national level, the funding is done through the local authorities. So baby homes is a residential childcare institution for children from 0 to 4 years old that includes children with disabilities who are either abandoned or relinquished or found and brought by relevant authorities or decision of the Commission on Child Rights upon the request of the Health Directorate. And it happened that in baby homes, most of the children, majority of them, they are not relinquished. And many children, they stayed for a long period. And upon reaching, completing 4 years old, these children, they were moved to the other type of residential childcare and childcare institution under the different authorities. In the country, we had 4 baby homes, 2 located in the capital city and 2 in the north part of the country. So UNICEF, starting from 2017, together with the government of Tajikistan, specifically with the Ministry of Health and Social Protection, transformed 4 baby homes into 4 family child support centers, serving 400-500 children. To compare with, like, currently we have the data we have as of July this year, we had 121 children in the residential care versus like, number of children receiving day type care support services, which is almost 400% more than children who stayed in the residential childcare institutions. Shall we move to the next slide, Beth? So, very briefly on the transformation process, what we've done closely with all partners, including ministries, local NGO, international NGO, and experts, local and international. So with the technical support, we developed the roadmap for the transformation of baby homes into the Family and Child Support Center. So this is done in very close consultation with Ministry of Health and Social Protection, since the policy is done by this ministry. Plus, we have done the revision of the regulatory framework. So we have the regulation of the baby homes now. So it was revised into regulation of Family and Child Support Center, where the working group was established, led by the Ministry of Health and Social Protection, and other line ministries were involved, including also UNICEF and the local NGO to contribute to this process. And then we have done with technical support capacity gap assessment and capacity building, since we have baby homes transformed into the family child support centers. So we did assessment of the existing staff, their knowledge and skills to work with the children, and what are needed to improve their skills. Since after the transformation of the baby homes, the staff that worked in the baby home, they received knowledge and skills to work with the newly introduced services in the Family and Child Support Center. So the other process included budgetary and reallocation. We did the mapping of the existing staff for the baby homes, and then the new staff required to provide newly introduced services. So we worked not only with the ministry, but with the local authorities to have to do that mapping of the staff, and then to see the to talk and then move with the reallocation of the existing budget to fund those staff and then operational costs for the Family and Child Support Centers. And accordingly, we developed the new job descriptions and positions to work with the new services. The good thing is, like, when we had the baby homes, we only had the staff, the medical staff involved in the process. But with the new type of services, we have the different other services, the social workers, the physiotherapy, and the new, we had the new experts who also joined the team to work as a multidisciplinary team. And then we provided also technical support to have the referral pathways, because baby homes, they were like, it had only residential care, But the Family Child Support Center looks also at the services which is outside, I mean, at the community level, and to work with the Commission on Child Rights, who is like main gatekeeping, who refers children to the services, and to have family support services and support the families and the children, to make sure that children are prevented from being placed in institutions, or children who are in institution to see to what extent they could be reintegrated with the biological families. Next slide, please. So the main goals of the Family Child Support Centers is prevention of child abandonment and family separation. So that's again, this is done through like liaising with the services outside the Family Child Support Centers. We have reunification of children from institutional care to family-based care. So we have children who are like placed in the, reintegrated with biological families and sent to also placed in the alternative family-based care in the country. So, and then we have also the improvement and rehabilitation of children with disabilities, and support and inclusion into primary and primary education of children. Next slide, please. So that's how it looks. We have a baby home, who is like for like children from 0 to 4 years old, that provided residential care. Now we have the Family Child Support Center, where it serves the services to children from 0 to 7 years old. So these are like different kind of services introduced, mainly to prevent and to reintegrate children, provide rehabilitation services for children with disabilities. For more details, my colleague Sonia will continue to talk about each of these newly introduced services in the Family and Child Support Center. Thank you. Sonia, please.
Thank you, Salahuddin. I really appreciate it. Next slide, please. Yes, so it's really interesting, as Innocent was presenting the situation in the country. I was recalling back the challenges and the situations that we have encountered during the transformation process. So same stigma, same attitude, and lots of behavior change work that had to take place from the top down, down to top approach, as baby homes, they were basically functioning for more than 70 years, and people were saying that, okay, why are you breaking something that was established and it's there, and we can just send children with disabilities to there, for instance, if the families refuse to take these children at the from the maternities to home. So that kind of challenges were there. And just to note that even though I have joined UNICEF in 2019, I was privileged to be involved in the project from 2017 and earlier on, together with the Healthprom and the local NGOs. And I really would like to acknowledge the technical expertise that was provided through the work of Healthprom, Hayot Daroila, and Sarchashma into the transformation process here. So basically, back to the structure, as Salahuddin had shared, Ministry of Health and local authorities are the ones who are guiding the work of family and child support centers. And when the family is referred to the center, then the admission department receives the family, they complete the registration and conduct child and family assessment based on the case management processes. And here the multidisciplinary team is really well established in order to understand the situation of the family and child, and to identify the relative services or the needs of the family, and only then they refer to the relative departments of the center. So in the new transformed family and child support center, we have the residential department remains, but it's temporary because there are still children that should be returned back to the family-based care, and this is happening gradually as the alternative family-based care system is being developed in the country. Therefore, we do have small residential care group, and we'll share more detailed information on that. And 5 days residential group is also under the temporary residential department for the working parents who need to place their children somewhere. The totally new support or service that was established in the new center is Mother and Child Department, and we'll share more about that. And of course, in order to prevent child institutionalization, and especially children with disabilities, the early intervention department was established here, and we will share more in detail of each service that is provided within this department. Next slide, please. So basically, when we were tackling transformation, and many of you are acquainted with the nurturing care framework, we were guided by this. We have the saying in ECD that 5 plus minus 1 is 0, and therefore we really needed to consider everything through the transformation process. The transformation falls under the security and safety domain here. Next slide, please. So I will not stay here a lot. So respite care under the early childhood intervention department is a planned or emergency temporary care that is provided to caregivers of a child. So sorry. So the respite care groups provide short-term and time-limited breaks for the families and caregivers of the children with developmental difficulties and disabilities. And basically in Tajikistan, we call it in Tajik language short break, which explains, it's very self-explanatory. And based on the family and child support center guidelines, each family can receive 30 days of respite care per day. And I would like to note here that the families, I greatly appreciate that, because they need it's the moment when they can breathe and just take care of themselves, and it's really positively impacting on the mental health of the parents and the caregivers. Just for an example, we were supporting the family, and the family required respite care for the child. So just the mother can take care of herself, to go to barber shop, to do something for herself. So and she returned from the self care time so restored that she, how to say, she decided not to leave her child with disability in residential care. And that kind of support in respite care really preventing child institutionalization. Next slide, please. And the daycare group is also an early childhood intervention group for the children with disabilities to support parents and children with disabilities in rehabilitation and functional abilities. So basically here already the children, they have their individual plans developed by the multidisciplinary team, and they go through the individual and group activities. They plan activities at home environment and involve not only the primary caregivers, but the extended family members also, because usually in Tajikistan, it is bigger households and young parents, they share their household with their grandparents and aunts and uncles. So therefore, we try to include the extended family members into the process. And also the here, the children receive support to get prepared to the pre-primary and primary schools. And we don't stop here and continue to provide our services in education setting in order to prevent the school or dropout of children, because we understand that the first months are quite challenging for the child and the family in educational setting. Next slide, please. And as I've shared before, that mother and child unit is very unique, and the first ever service that was established within the center, and it is designated for the temporary stay of a mother and a young child who are in a difficult situation, and the mother who are considering to leave their children in residential care are the particular focus of the services. And these services also provided to the pregnant ladies in last trimester of the pregnancy to support women in childbirth and neonatal care. So basically for the 6-month period, the mother and child can stay at the unit and receive social and medical support. Next slide, please. Temporary residential care, as I said, that unfortunately still we need this support. We did return children back into the family care gradually through connecting the families and children and explaining the effects of institutionalization on the children. But this is the new way of work of the temporary residential care is inclusiveness, as children are not isolated as before, and they can attend to a learning and other activities with other children in the community. And also social workers during this period of time, they work strongly with the extended family members and the local authorities to identify if the child can be returned to the family or the alternative family care. Next slide, please. And 5-day residential care basically provides services to children whose parents work in shifts or who do not have permanent housing. And this kind of service provides an opportunity for the caregivers to meet with their children and spend their time during the weekends. And while the children and the family are getting these services, the social workers are trying to improve the housing and living conditions and provide this support. And the time period of the children who are staying in the 5-day residential care depends on the individual situation of the family. Next slide, please. And I would like to also highlight the home visiting practices that are integrated into the system. We all know that the home is the optimal environment for the child development, and therefore we really need to understand how the child can develop at home and create the space and the environment at home through the occupational therapy and physical therapy, and not only that, but also to work with the extended family members so they can create responsive environment at home. Next slide, please. And basically few pictures from the family and child support centers. It's impressive to see that the grandma on the grandpa on the picture, he's coming with his granddaughter for the activities for the individual sessions, because the parents are busy at work and he is taking care of this. This is very symbolic in Tajikistan because men are usually not involved in child care practices. And also the CBR or rehabilitation is conducted at home, and the staff workers, they train the caregivers to take care of the children at home. And it's very lively, it's very active, where previous baby home practice was very conservative ways of working, but currently children have more physical space and more opportunities to be engaged in the activities. And the center is open to the parents' visits, and there is a parents' rooms where children and families can spend time together. So basically, this is very briefly about the work that is done here. And once again, I would like to appreciate the inputs of all partners who had did the marvelous work in the transformation of the baby homes into the family and child support centers. Thank you.
Thank you, Sonia. Amazing presentation, and really nice to see these pictures as well. Take a moment to look at the chat and see people's appreciation for what you've shared. I think I can speak for all of us on the call and say just a big round of applause to Sonia, Salhodin, and Innocent, to UNICEF and Hope and Homes for really sharing this learning with us today. Let's go to a few questions, and I will welcome people. We have about 20 minutes, so welcome people to unmute and turn videos on and join in the conversation now. And let me just go first to a question that I think goes to really to both. It's interesting that Innocent and Sonia, you're describing early childhood centers as a focus, and Leah is just wondering, is there a partner that has been supporting with the sort of early childhood technical advice as you made that transition? So maybe we can just go to Innocent first. Innocent, did you work with any other early childhood partners to really make that transition possible?
Would you also allow me to first appreciate that although we are talking from different contexts, it looks like whenever you see the problem very closely, the solutions, because the needs are quite similar, the solutions can be designed in a similar way. So I really appreciate, I'm impressed and happy to know that the experience between the two countries looks complementary, and each one can improve. So it's fantastic. Yes, we were, I mean, in Rwanda, there is first of all an agency in charge of ECD, a national agency called National Child Development Agency. It is a fusion of the former National Commission for Children and the National Early Childhood Development Program. So they were brought together, And it was a perfect connection, if I could say, because the NCC was the National Children Commission was focusing much on the reintegration of the right of children in general, while the National Early Childhood Development Program was focusing much on nutrition, on building those centers for young children. But now it is coming under same house, which give even the social workers with additional means when they are closing an institution to bring into the key stakeholders, the specialists, because there are specialists. So the National Early Child Development Program brought its own specialist. And now, for example, for these centers, both centers, they have already started receiving additional support from the government, which should have maybe gone through a different process or a difficult process, but because it is now housed in one agency, it is going in parallel by the same staff talking to each other like one team. And the National Council for Persons with Disabilities, because they are working closely. I will say that this came also as a development because the council was much focused on those who can express themselves. I can't say it loudly, but by reintegrating children, they became more sensitive also to young children, to centers that need to be transformed. So it was also equipped and it has started supporting. And the last point is about the close monitoring. So here I'm talking about the national levels, but the district has a mandate of monitoring these centers, and this was achieved through a clear partnership agreement. So clearly signed, clearly everyone knows the role, but the district has the mandate to oversee ECD, how they function. That's how I can respond on that.
Thanks, Innocent. I think it's really important to hear about how you partnered with those disability organizations in Rwanda to make that happen. Sonia or Salahuddin, any other thoughts about kind of who should we be looking for in terms of partners to advise in terms of transformation?
So basically, for Tajikistan, early childhood development is relatively new concept in the understanding of ECD within UNICEF and globally. So therefore, for us in the transition or the transformation period, the great technical advice in the project was provided by the experts of Healthprom UK, and we have brought this technical expertise into the country, have modeled it, piloted, and adapted, and received Ministry of Health support on that. And basically, yes, so we are still developing. So and also there is a strong network of parental organizations on ECI, ECD, and everyone is trying to build the pool of expertise so we can continue developing inclusive ECD in Tajikistan. So not only the Ministry of Health and Social Protection is being involved, but other relative ministries such as Ministry of Education and Science, and also the local authorities who are mostly the decision makers in the scaling up and integrating of the resources and programs. Thank you.
Thank you, Sonia. Can you just say quickly, what is ECI? Oops. Okay, maybe we can do that in the chat. Let's see, can we go to Jonathan? Would you like to unmute and ask your question or make your comment?
Oh, hello, Beth, and hello,
Hi.
everybody. Hi, yeah, this is Jonathan. Thanks very much for including me. I'm the project manager with HealthProm for our work in Tajikistan. And thanks so much to Sonia and Salahuddin for your really interesting description of what happened. I just would be grateful of a moment to just describe some of the drivers, some of the incremental approach that led up to that. And just sort of to acknowledge the partnerships really and how they all work together. Because I think that's interesting to, as it shows what needs to be in place, for all these wonderful changes that Sonia and Salahuddin described, for them to happen. So just very briefly, and I promise, Beth, I won't take more than a moment. It was the government of Tajikistan through the City Health Department that originally, back in 2006, spoke to HealthProm about supporting families so that they didn't abandon their children to the baby homes. And then that led to a series of development projects, which were funded by mainly by the European Union, but with also additional funding from DFID, the British government, and the government of Canada. And that allowed for civil society to strengthen, and a number of local NGOs, in particular Hayat Daroila and Sarchashma and Eroda, developed family support centers, which eventually, which became a model for the new family and child support centers that Salahuddin and Sonia described. So I just wanted to give that sort of international background drivers, and just to mention that other elements are really important as well. We were extremely fortunate to have input around international best practices as over time, and as adapted to be relevant in Tajikistan. So specifically from the government of Scotland, who contributed our safer care and development approach, which is sort of formed the core of the family support services, and the parenting program from Mellow Parenting, another Scottish NGO that contributed locally relevant international practice. And together with a foster care element and alternative family care, we put this into a training package and delivered that over time, over many years, and in fact over several projects. And really finally, it's been really important to have a strong monitoring and evaluation process, and the Centre for Excellence in Looked After Children has provided that, and fed back through a process of learning to refine the change. And all of that has contributed to just driving the process in partnership with the Government of Scotland and with UNICEF. So thanks for the opportunity just to give that little bit of cut the cake in a different way and explain the drivers, so the how as well as the what.
Thanks. You so much. Thank you so much, Jonathan. Really, really important inputs. A couple of things that strike me sort of across context. I love that you're mentioning that importance of monitoring and learning, and really using that to adapt as we go along. I love that you're mentioning how many years and the time that it takes for this transformation to happen, as well as the costs. I think that's a really important aspect to consider. And recognizing that you had the resources from donors to help support that process. I think that's important. Thank you.
Thank you, Beth.
Sorry, Victoria, I see your hand. So let's go to your question next, and I'll just check the chat for any additional questions.
Hi, Beth. Hi, everyone. It's Victoria here at Open Homes for Children. I'm a colleague of Innocence, so my reflection is aligned with what he's presented today. And I think I just wanted to, what was running through my mind was kind of the shift, or the concept of micro and macro when we're talking about No Child Left Behind, and the kind of the shift that we've seen across a decade of work in Rwanda. So, you know, the concept of no child being left behind is such a fundamental principle, and I think it took two forms in Rwanda. At first, the first phase was very micro. It was around the individual child. So when we were closing those institutions, the typical orphanages that Innocent was describing, it was about not leaving any individual child in a particular institution. So naturally that meant developing all of the inclusive services, alternative care services and community-based services that were required to make sure that no individual child was left behind. And that was on a very micro level. And then the second phase of work that he was describing was really the macro level. So looking at systemic change, so that demonstration and evidence from the micro level being used as a lever to really unlock the systemic change so that no child is left behind in both national strategy and implementation. And that took the form of things like, you know, research and evidence, our national survey of children with disabilities in institutions, knowledge, attitudes and practices, and then the implementation partnerships that Innocence described. So I don't have a question here, but I think it's just maybe a reflection on the longevity and the amount of time required to invest in these principles, and how each country is really going on a journey, and where that journey starts and whether it's at that micro or macro level will be different in each. And we certainly have seen differences across all the countries that we work in as to whether the levers are at the national change level or starting at the local level. But it's something that, you know, I've seen reflected in the presentations for Tajikistan, and perhaps just something for us to all take away, you know, where in that journey and where is the lever within the system for us. Thanks, Beth.
Great, Victoria, great point. And how do those that sort of macro and micro come together, bottom up, top down, however you want to think about it? I think working at all those levels, really important, great input. Let's turn to thinking about stigma. So I would love to hear from others who are on the call. I think there's a lot of experience here in this group that's coming together today. So what are some of the ways that you all are addressing stigma? And it doesn't need to be Innocent or UNICEF answering. I see others on the call as well. How do we begin to tackle the challenges around stigma in families, stigma in communities? Yeah, go ahead, Leah. Leah from CRS, I think, yeah.
Hi, Beth. Yes, my name is Leah Eisenhart. I'm the Senior Technical Advisor for Disability Inclusion at Catholic Relief Services. And I was really intrigued by Innocent's most recent comment in the chat about how peer support groups for families contributed to reduced stigma. In the stigma work that anti-stigma work that we've been doing in our family strengthening and reintegration programs at CRS, we've been paying attention to those different levels of stigma. The stigma that's experienced by the caregiver from the community towards the caregiver, from the community towards the child, the stigma that the parent themselves or caregiver feels towards their child and feels towards themselves. And so I think that when we're talking about stigma, we have to think about those different levels, and whatever intervention that we're using, we need to pay attention to what type of stigma it is reducing. And so I was wondering if we could hear more from Innocent about the type of stigma that was reduced through those peer support groups, and how you measured that, because I think the measurement around stigma reduction is also something that's getting a lot more talk in our sector. Thank you.
Thanks, Leah. Any insights there, Innocent?
Yeah, this is a very challenging question, and but I will try. I like the question.
It's a community of practice, so you don't have to have the right answer.
Yeah, I'm not hiding behind the fear. So I just wanted to say that the way she has just described, if I'm, described the level of stigma is correct, and something again I'm saying we are learning, but I will much focus on what we've seen and what we tried to do. So first of all, we recognize that children with severe and profound disabilities are hidden, completely hidden, cut from the world, and no one really knows even if they exist within a certain family. So the first focus was to make sure they are even known, they are seen, they are put outside, they live like anyone outside, being confined, closed in a one room within a house. As that was the extreme level. So it wasn't like we bring professionals to go and educate parents. We wanted these structures that are community level, the NCPD, National Council for Persons with Disabilities, who were already voted by their peers in the area of disabilities to have campaigns and make sure they form groups so that a parent can influence the other parent who has a child with disabilities, and the connection will be much easier. So by coming together, now the professionals could join their discussion groups and look at which level, and here I'm talking about our psychologists and our social workers, they will have an elevated analysis of what they are observing. Because as the description was clear, parents themselves do not accept having a child with disabilities. They start conflict within the family. So in a way, they decide, it's a process that comes from their mind, intentionally or unintentionally, to exclude the child. But we had also to consider the element of those pejorative names, very, very negative names. They are fought by the laws, but we wanted to make it a campaign, an awareness campaign. We are like in Rwanda, we use all Kinyarwanda. So by providing clear messages on radio and social media, we've seen even some progress. This may require a systematic assessment. We have already conducted one of knowledge, attitude, and practices. Maybe we can share that. In Rwanda and Uganda, after a certain time, that's when we can affirm 100% that we've seen this progress happen. But it's something at the field level, we see, at least in those communities we are serving, plus the use of technology. We introduced the SMS technology so that whoever knows a child who is hidden or who is being abused, the person report it, not on one person who may be indifferent to the request, but through a channel of different actors. So you'll find that there are 3 people at district level, 3 people at national level. So you can't hide when there is an alarm, when there is a call. So I will say that all those, I may not describe what happened at the child level, at parent level, at community level, but all those elements has made even the government more courageous to start a DMIS. It's how do you say, data management system that is being piloted to make sure every single child is known and how they are treated is known, plus a case management package that will follow. So I will say that we can, the stigma is not removed, the discrimination is not removed, but talking about it and giving the opportunity to persons with disabilities through the peer support group has really brought them to come forward and challenge whatever they were not okay with. So, but it's something we can continue following up.
Thanks so much, Innocent. I think, again, really interesting in the chat and with what you're saying, there's it has to be addressed from multiple different levels in multiple different ways. Jared, I see that you've turned your video on. Did you want to add something to the conversation before we wrap up?
Yeah, I'd love to. Obviously, stigma is something we've been working on a lot over here at Akisa. I'd love to just add, what we've learned is, one, I would say just, off the cuff, that probably 90% of stigma and discrimination doesn't stem from, hatred or evil. It stems from a lack of education. And what I found in a lot of developing countries is just most people have never had the opportunity to be educated about disability, to be sensitized to encounter persons with disability. And so because of that, you fill your head with assumptions, false knowledge, that kind of thing. And so for me, it's really encouraging because it's a very solvable problem. If you can just get in front of people and provide them with basic education, you can make leaps and bounds and jumps in somebody's worldview and get rid of some of those, negative attitudes that they have towards persons with disabilities in a kind of a relatively short amount of time. We very much agree, like the peer groups is a huge part of what we've seen success in for that. And one other thing, like on the topic of stigma, that is really important to us as we look at how it correlates with reintegration. So Innocent shared that reintegration kind of process flowchart that they have. One of the things that we recognize at Akisa is when we first, if we're going to assess a family for possible reintegration, the first question we always ask is are they willing? And often the answer is no. And it's easy from a social work perspective to say, listen, if a family is negative and they're not willing and they have a completely negative and it's a huge potential for abuse and neglect, we're not even going to try with this family. But because of stigma and because of lack of education, we know that often the unwillingness to have a child reintegrated into family comes from that. And so rather than kind of giving up on the family and moving right into alternative care, we begin to assess what are those barriers? Why do they hold this negative opinion? Why do they feel like it's not possible to have the child back? Why are they not putting forth any effort to visit the child? Those kind of things. And how can are those solvable problems? Is it an education issue? Are they making false assumptions about the amount of support they'll receive after the time of integration? And we've seen success in that. And it's hard to kind of find the balance between how long do you keep working with a family and trying with a family before kind of giving up and moving on to other alternative care options. But because we know there's such a lack of education and there's so many false assumptions, that we want to make sure we give really adequate time to kind of changing the mindset of a family before we would look at alternative care options. So.
Excellent points, Jared. Thank you so much. I was just typing in the chat. I really want to welcome all of us to continue this conversation. Lots to talk about. I think we could have probably gone on for another hour of just really exchanging ideas and hearing from everyone on the call. So let's use the platform, our community of practice that we have on the Transforming Children's Care platform to continue the conversation, to continue to share experiences and resources. I will look forward to all of your ideas about what we discuss in our next meeting. Maybe it's a continuation of this conversation. And just huge thanks again for a great session today, for Sonia, Salahuddin, and Innocent for your contributions and being willing to present. And maybe just as a final word, I noted just the important thing that Sonia said, which is that behind all of our work are the humans, the people, the families, the social workers, the children, first and foremost. So really great to see you all today, and thank you so much.
Thank you.